Some patients need a little bit more push. Some patient needs a little less push. Some patients maybe don't want to be pushed at all. So that controlling of forces, how much of your mass, your body mass you use when you deliver the treatment, I think that matters some. Maybe not for clinical outcomes, but it definitely matters for safety. And I think it matters for patient comfort as well.
All right. Welcome, everyone, to the AOMT Hands-On, Hands-Off podcast. My name is Lena McDaniel. I'm a physical therapist. I'm a fellow of AOMT, and I am just thrilled to have you all today join us. I think it's going to be a great episode. We are so fortunate today to have Dr. Casper Nim from Denmark. He's a chiropractor and senior researcher at the Spine Center of Southern Denmark. He's an assistant professor at the University of Southern Denmark, where he completed his PhD in 2021. Welcome, Casper.
Thank you.
Yeah. So just to kick off the episode a little bit, we do want to focus on one of your recent publications, but before we get into that, can you just introduce yourself a little bit to our audience and tell them briefly about your background as a clinician, a chiropractor, and then as a researcher, and what are your professional roles right now?
Yes, absolutely. That's not a problem, and thank you for having me. I really appreciate the invitation. It's gonna be a lot of fun. So you said my clinical background, which is actually an interesting story. So I'm educated from the University of Southern Denmark, which is an unorthodox chiro program, I would say, because it's based 100% in a medical faculty. So we study alongside medical students, which also means that, some of the raw philosophy of the chiropractic profession that it has in the background, right? We don't really have that in there, and we're really well integrated into the healthcare system. So I clinically, I worked almost my entire career at a hospital diagnosing patients. So I actually don't have that much experience with hands-on treatment. And it's interesting because a lot of my research is centered around that. So I always get the, discredit from the clinicians that I don't understand this because I'm not doing it in real life. I don't see all the potential and stuff like that. But I'm always flipping it around saying, well, I also don't have that bias, that I, that I see it work. So I can be completely, objective and just, stay within the limits of the data. And I do think there's some benefits to that. Although I do appreciate clinician researchers as well. But mostly what I'm doing now, I'm still doing a lot of manual therapy research, different related projects. But to be honest, it's all my hobby projects at the moment. All of my funded research is mostly related to more healthcare utilization and, long-term patient courses and mapping those, and more into the world of epidemiology. I'm slowly evolving into that. But I still love doing the manual therapy work, and it's a lot of fun. And sometimes, good stuff happens, like the paper we're coming into now, right? A completely unfunded project we just all did in our spare times. It was a fun and frustrating process, to say the least.
Wow, that's incredible. And it's amazing to hear that lead off into this study because of what a massive study it was, and just thinking about all the aspects of it and how many people were involved. So, well, great. Well, let's jump into it. I want to hear more about your perspective on it and kind of the background behind it. So the main publication that we do want to highlight and talk about today is a recent publication, a 2025 article in JOSPT titled "The Effectiveness of Spinal Manipulative Therapy in Treating Spinal Pain Does Not Depend on the Application Procedures, a Systematic Review and Network Meta-Analysis." So this paper that just came out, just quite a lot to it and really rich with opportunity to kind of pull some findings from this, and we'd love to hear about it. Can you briefly describe the study, the design, and kind of the underpinnings of this study for us?
Yeah, absolutely. And if I'm allowed to, I'll go a little bit back in time, because ever since I was a student, and I graduated 8 years ago, so I don't want to admit it, but it's a few years ago now. But I was always very critical of this notion that we were taught that you could do spinal palpation and then feel, wherever the dysfunction was, and then you could hit, exactly at that segment, and that would help, basically cure people sometimes, right? And it's and I was really challenged then when I got into clinical practice, because I have been in chiropractic practice for a little bit. And so I thought that was quite difficult. So when I led into my PhD, which was actually, to be honest, when I was young, back in 2016, 17, we wanted to predict responses to spinal manipulation, or I'm just going to call it SMT. We wanted to predict responses of SMT using pain sensitivity and spinal stiffness as like biomarkers on where to give the treatment. And what we really noticed when we looked at the data was that it was like the participants in our study got the exact same treatment. Like they completely changed, identical of each other, those two groups, as in completely identical, as in it was the complete same treatment we gave them. And that really opened up the door of looking more into that. So we did the first original review as part of my PhD back in 2020, which was published in Scientific Reports, where we looked at the target site and didn't see any differences. And when we published that, we had a huge critique from a lot of clinicians, both physios and chiros. Everyone kind of hated me a little bit, at least in public. Private, I got a lot of positive feedback, but in public, everyone disliked the study. So so some of the critique points that we got there, we did in another JOSPT review that we published in 2023, where we looked at it. We removed some of the heterogeneity from the original study and then focused a little bit more on a certain population, and found the exact same thing again. But we were still only looking at one aspect of it, which was the target selection. So
Right.
over the last couple of years, this network meta-analysis approach really came up, and there has been a lot of network meta-analysis. I think in 2023, it was something from 2020 to 2023, there was almost 400 network meta-analysis published on MSK research. So it exploded all of a sudden, and it does allow mathematically that you can actually compare two different interventions that are not being directly compared within the same study. So that's the indirect evidence. And there's a whole bunch of statistics that goes behind that, which I won't get into too much here today. But this did allow us to actually classify all of the different SMTs that were delivered in studies, and then compare those classifications to each other, which meant that we could look at other things now than just target selection. We could also look at the thrust specifics, and we could even look at the region where it was provided. And those were the three things we went with. So we basically wanted to, yeah, sorry.
Casper, I think all that's great. I just want to interrupt you briefly because in reading this study, I'm familiar with some of these terms that you're using, but just for our listeners who may be less familiar, could you briefly define SMT for us? And then can you briefly define the target? What do you mean when you say target?
Yes, of course, sorry. Yeah, no, SMT, I don't think there's a quite clear definition, but basically it's the cracking manual therapy. So it's the manual therapy that has a high thrust and a low amplitude, high velocity, low amplitude, and it often results in a cracking sound. So we actually in this study excluded like other types of mobilization. If you follow the Maitland criteria, maybe the listeners are more familiar with that. This will be a grade 5 mobilization. So it was only the popping manual therapy that we used for this SMT definition. Sometimes mobilizations are being put in there, but for our study, we just looked at the cracking therapies, so to speak. And when I say target and thrust, what I mean is by target, I mean where do you decide on where to give the treatment? So there's a huge literature and even profession-specific debate about where to do it. And it can go with, like, the classic thing, at least in chiropractic, is that you palpate the spine and then you find these dysfunctions that, the fixed joints or the lock joints, typically around the facet, and then you manipulate it, you make it go the little cracking sound, you get the burst of the bubble and those theories that we can get into if you really want to. And that improves the patients. So, and you have to deliver it at the exact right spot, right? Because everyone can make their back say crack, but it's not in the right spot. That's the whole theoretical foundation around it. So when I say target, that's what I mean. That's basically where exactly is the intervention, where is SMT being targeted on the spine. And if we go with thrust, which we also looked at, that could be like, was it a specific thrust? You try to hit a single vertebral segment, or was it more of a generalized thrust, like you wanted to manipulate an entire lumbar region, for instance? And the region, I think we split it up into the region of pain. So that could be low back pain patients with, manipulated at the lumbar spine. But it could also be, let's say, patients with cervical, like neck pain who were treated in the thoracic spine. That could be the non-symptomatic region. So that's how we defined regions. So those are the three things that we wanted to assess in this review here, where we could only look at the target earlier.
Great, thank you. I think that really helps. Can you speak a little bit more about how this study then came about? I kind of got you off track, but thanks for those definitions to kind of clarify.
Yeah, you're welcome. Yeah, it's always when you gotta speak to a broad audience. Sometimes everyone doesn't really understand what SMT is. I mean, sometimes we can't even define it. So it's a good point. So the study came about in, I believe, 2022. I had the idea about doing this, and then I engaged Carsten Juhl, who's a professor at the University of Southern Denmark. He's also a physio. He has done a lot of systematic reviews. He's like an expert on systematic reviews. And I told him about the idea, and he really liked it. And then we pretty much got going. Then we got a senior team together. So we got Chad Cook, who I'm sure most of your listeners are familiar with. We got Chad involved in it. And then we got Jan Hartvigsen, who's a professor also at the University of Southern Denmark at chiro. He has done extensive work in the low back pain field. Like, he was an author on the Lancet series, for instance. So a very good guy. And then we also included Stephen Pearl, which I think your listeners probably won't know. He's also a chiro by training, and he's retired now, but he has a mind of his own. Like, he knows every theory, every treatment. He's a sponge. He remembers everything. So we included him as well as the senior team. And then we had to find, people to actually do the work, because we all know that professors don't really do a lot of work. So so we had to get a huge review team. And originally not originally, but I'm a part of the Carl Fellowship, which is like international, I want to say research and leadership international chiro program. So we were 14 people in the program, so we got a bunch of them in, and then we realized, holy moly, this is going to be a lot more work than we anticipated. So we got more people involved in it, and that's where Megan Donaldson came in, for instance, also with A-armed. And at every point, we wanted to keep it very interdisciplinary. Like, that was very important for us, because there was some of the critique that we got, especially from chiros from our prior reviews, was that, well, all of this work was done by physios, which was actually most of the other studies that we included. But here we had a possibility to include, from all types of different professions, because we looked at it more broadly. So we also wanted to make sure that we had a very broad and interdisciplinary and international team as well. So we also had a sports science guy. We had a lot of, like you said, I think we were 18 authors. So we had a lot of different people in there. But that's really what it took to get it done. It was a huge process when we got it going. The search was big, and then the data extraction was enormous, because we had to extract a lot of things to classify these different SMT interventions. So yes, a lot of process that I think we worked on it maybe a year and a half before we attempted to submit it somewhere. So it was quite a lot of work to get it done.
Yeah, it's amazing. Just an enormous data set. So going through kind of the introduction, there were, I believe, in your final sample, 161 total studies, a little over 11,000 total subjects included in this. Can you speak to how you managed that large of a data set and your choices of some of these statistical methods to analyze the data? And then I think you mentioned some of the variables that you were studying, but what were your main outcomes? What were you looking at as a result of these SMT procedures?
Yeah, let's start from the beginning. How do we manage it? Luckily, I'm a quite organized and structured guy when it comes to data management. I'm also pretty sufficient with the statistical software program that we used, but it was really, really difficult, and it was reported in just a number of different ways. So there was a lot to keep track on where we actually got the data. It took some time to prepare the data for analysis, and then the analysis itself took maybe 10 seconds. So that was that was kind of a bummer, but probably took 2 months to get there. That's the thing about data cleaning that, as non-researchers, you often don't appreciate as much, because you're like, well, you get the results, but sometimes the results takes months to even get to a point where you can analyze the data. So that took quite a lot of work. I also had to really understand this network meta-analysis thing, which is quite it's quite different than a normal meta-analysis from a math standpoint. So I had to put my head into that as well. So that really did take a lot of time. Yes, and then we extracted, like I said, a bunch of information. And for outcomes, we decided quite early on that, because we knew we were going to end up with a broad, very heterogeneity kind of study sample here. So we went with the two outcomes that we at least knew that probably the majority would publish, which would be pain intensity and some kind of disability measure. So that was the two outcomes that we selected. And then we were strategic and saying that we will only look at, right after the treatment. So right after the treatment, like the intervention, if it was 12 sessions, it would be after that 12 sessions. That would be the short-term outcomes. And then we had the long-term outcomes, which was the closest thing to 12 months. So those were the outcomes that we selected, which meant that we had to do a lot of analyses, because we did a lot of networks, and each network had to be repeated for different outcomes at different time points, which is why the study the paper got so enormous as it did.
Right. Yeah, absolutely. So after all of that, after collecting all of that data, what did you all find?
Well, I think we found a number of things. The first thing that kind of pops up is that we mirrored what the other systematic reviews have found, which was really positive, because our systematic review here was more broad than, let's say, Sidney Rubenstein, who published a systematic review on chronic low back pain back in 2019. That was probably the biggest, that was the biggest SMT review to date, published in BMJ back in 2019. And that was a little bit more concrete. Ours included, different regions, a lot of different techniques, different, durations of pain. We had both acute and chronic pain in there. So that's why we ended up with so many studies and so many participants. So we were happy to see, first of all, that our results actually mirrored what they found, which is that SMT seemed to be as effective as other interventions, recommended interventions, such as exercise and other manual therapies. There was no real difference there. And also that SMT was, a little bit more effective than non-recommended therapies, like, say, putting yourself in traction, or like ultrasound, for instance, and like stuff that is no longer being recommended in clinical guidelines. What we did found that was different from a lot of the other reviews was that when we compared to sham treatment, we actually found quite a larger effect of SMT compared to other studies. And I think part of that is due to we had to pool some different placebo studies together. So one could be a real setup where you completely mimic the intervention, and the other one could be like a detuned ultrasound thing that you just put on patients. And from a contextual standpoint, which we'll talk more about later, those are very different. And we also know that from a paper published in Pain last year, that there's quite a big difference in the effect sizes between those two different placebos. So that's probably why we found those results. So that was the first thing we found. And then we basically used different ways of categorizing the target, the thrust, and the region. And then we compared all of those with each other based on this advanced and complex statistics. So we got a result out, and that result was very clear. Like, it worked, and it really didn't matter how you used it. Like, there were no real differences between any of the SMT interventions. It reached statistical significance a couple of times, but it was still a somewhat small effect size. So basically saying that SMT seems to work as well as other recommended therapies, but how you do it, like, it didn't explain any of the variation in the outcome data. So there was no difference whether, let's take an example, whether you used a completely generalized thrust or whether you were trying to be like sniper specific on the vertebral segment. Didn't matter. Even if you did it in the region where people came in, like, let's say a neck patient came in, you manipulated the neck, or you manipulated the thoracic spine. There was a lot of studies that did that. Also, no difference in neck pain outcomes or neck disability outcomes. And we actually found, but that's not what we want to conclude, because I'll get to that in a second, but we actually found that, a completely non-specific approach, a generalized thrust to the non-symptomatic region, actually appeared to be the most effective way of doing it. But because of the way that the study was set up, we said that, clinicians, and that's the main takeaway, that clinicians can basically do whatever they want to and expect to get the same results. So we shouldn't, dive into the different philosophies or theoretical frameworks for, this type or this type. At least on average, it seems to be that there is no real difference. And we found one last thing, which I might add, which was that, as expected, because we did normally in systematic reviews, you do a grade approach to assess the certainty of the evidence. And normally you want to get like high certainty evidence. That's what's going to change clinical practice, basically, which rarely happens in spine research, unfortunately. And it also didn't happen here. We actually got low certainty evidence more or less all the way through. But it is really explained by a few things. First of all, you always assess risk of bias in these randomized trials that we included. And here we were very stringent. We used Cochrane's, which is the recommended tool, and we were quite hard. So we used Cochrane's way of doing it. And Cochrane is it's like the guidebook on how to do reviews, basically. Which meant that almost all of the studies were categorized as having a high risk of bias, just because you cannot really blind it. And all the outcomes we looked at were subjective. So I would say my pain is now 3 out of 10 instead of 5 out of 10 or whatever. And that's all a subjective opinion that can be biased by a lot of different things. It kind of makes sense, right? So that pumped the certainty of the evidence. It downgraded it, I would say. And then we also saw some inconsistencies. So there were some comparisons that we did, and I don't want to get too technical here, where we had a study that did a direct comparison. So let's say an RCT that compared SMT to exercise, for instance, and that would show one result. And then based on all these advanced mathematics, when we looked at the indirect evidence, so that would be if we took what the computer decided is probably the effect of manipulation over exercise, those two could differ a bit. So that's what we call inconsistency. And we also had a little bit of that. And it was mostly related to when we compared SMT to other interventions. So again, basically saying that the outcomes we looked at are all over the place, which did impact the certainty of our evidence. But we still, and I don't know if you want to ask about this later, but we actually still conclude that, and we just wrote a blog to JOSPT about this, where we explained this in more detail, which didn't fit into the original paper. We still believe that this has an impact on education specifically, and also on clinical practice, because it's not only this paper that says that. We had the other reviews, we have individual trials, we have mechanistic research saying that you can't really control forces, or at least control where the forces are delivered. Like, for instance, if you were to quantify where the popping sounds occur, they occur all over the spine, even multiple places away, and only like half the time they actually occur on the segment. So this aligns really well with mechanistic research, with other reviews, with individual trials, and also, to be honest, with a more modern understanding of pain science, and how back pain is fluctuating, and this how complex pain really is. It also goes along really well with that. So we still think that our conclusions holds a lot of recommendations that we hope will be implemented different places, despite the low certainty evidence from a more statistical standpoint, if that makes sense.
Yeah, I think so. Thank you for the explanation and description of results. The first thing that kind of comes to mind, and I don't mean this in a negative way, but being fellowship trained and AMPed, and just having some conversations with colleagues about these sorts of things, we like to think that our training allows us to deliver maybe different levels of manual therapy skills than colleagues who maybe didn't go through residency training or fellowship training, or just don't have the experience. What are your thoughts on the potential impact or implications of, as you yourself mentioned, just the large data set and potentially the heterogeneity of the different studies that were included? Was there any way that you were able to control for or account for the type of treatment delivered, whether it was from a trained clinician? And then can you speak to maybe the breakdown of different applications of these treatments from a chiropractic standpoint? Is probably your lens, but also the chiro philosophy versus physical therapy. Do you think that made a difference? And again, acknowledging that, including both of those professions, because we both utilize that as a treatment technique and trying to span conclusions from application of this treatment is important. But do you think that limited your ability to conclude definitively things based across the board? I don't know.
Yeah, no, Yeah, no, I know what you mean. There were two really important questions there. One about
Okay.
the ARM training and all that stuff, the class, like the to get those qualifications. Let's get back to that in a little bit because I do want to answer that. We can take the study first. Obviously, the effects that we see here are all averaged effects. So it might be that there are certain outliers where this matters a whole lot, and other outliers where it really doesn't matter at all. But on average, there was no real difference in it. And that's currently the only way that we can look at it is using the average data. And then you asked about, I would say first of all, our study was, despite the large number of studies, was not really powered to look at whether different professions differed or whether the experience of different professions, if that mattered for outcomes. There are some other studies out there where they look at the experience of people and how that matters, and it doesn't seem to matter a great deal, which also boils down to the complexity of measuring pain in real life. It is quite complex, and even just to understand that and interpret it as a research participant, very difficult. And then I would say we deliberately also didn't want to compare clinicians against each other
Right.
because there are a lot of other factors that are involved here into the effect of these studies. So let's say like the smaller sample sizes of some studies, for instance, that's something that probably matters. Risk of bias may matter as well. But we did, and I haven't talked about this yet, but the paper is about a couple of pages, but then our supplementary material, our appendix, is actually 340 pages. So we did we did numerous additional analyses kind of to validate or verify some of these findings. And some of the things that we looked at that didn't matter was, where did the patient have pain? What was the pain duration? But it was all more patient-specific criteria. We didn't really look at the clinician itself. But and I kind of don't want to do it, to be honest, because I don't want to set chiros up against physios. I don't think that makes any sense. We should probably be better at collaborating than fighting each other. Um, and it doesn't really have any impact, I would say, on clinical practice because we all know on an everyday basis, right? If patients, they like to go to chiros, they'll go to chiros. If they want to go to physios, they'll go to physios. And if one thing doesn't work for them, maybe they'll switch. But the risk of going back to a provider is who you see first, most likely. So I would kind of hate doing research like that, especially on this type of database. And when I say all this, and I get back to your first question, which I thought was really good about the ARM classification and postgraduate education and all that, I do think that matters greatly. So there are 2 points in all of this that we haven't been able to assess. And one, if you want to start with the biomechanics, is force modulation skills. So, for instance, the more trained you are, you would understand that some patients need a little bit more push, some patient needs a little less push, some patients maybe don't want to be pushed at all. So that controlling of forces, and I don't mean where right now where it's being delivered, but by hand forces, how much of your body mass you use when you deliver the treatment. I think that matters some. Maybe not for clinical outcomes, but it definitely matters for safety, and I think it matters for patient comfort as well, and also for participant comfort, or not, for provider comfort. And that's the next thing to go into here, because I think a lot of this is being driven by contextual factors, to be honest, where manual therapy in general is a very powerful contextual factor. Like you lay down, you're being examined, and you something is being done, and the patient can obviously hear and feel that something happens. And if it says, at least in chiro field, and I guess also in physios from some of the conversations I had, whenever it says that popping sound, you always get a little bit, yes, that was really good, right? You got a good response. And that response, that rubs off on the patient. Obviously it does. And they will get up and say, yeah, I can feel I move much better now. And all of that is probably has more to do with context than what actually happens inside the spine. And that is something that is being portrayed better by, and this is just me, I don't have any data on this is just me speculating, but I would say that is easier to sell if you are an experienced clinician who trained this and has a high confidence. You can easily build up this therapeutic alliance. You can more easily, wrangle your different techniques, your force modulation skills, and all of that. I think that matters to a certain degree. And it's that stuff like that is just difficult to learn. because you need to be comfortable doing it and confident doing it. That way, patients will also be confident and comfortable in you doing it, and that will lead to better outcomes. But again, that has nothing to do with the way you do it, which is why that we make the argument that clinicians, like experienced clinicians such as yourself, you can go out practicing tomorrow or next Monday, and you can do whatever you want. Probably won't matter a whole lot. You can try to be as specific and as concrete as you want, whether you're a physio, a chiro, or whatever it is. But for the future clinicians, I think we are basically looking into a major paradigm shift of the way that we the way that we teach manual therapy, into an approach where we have to look at it. I want to say the word holistically, even though I hate that word because there's so many negative associations with it. But we have to see the whole person. We have to understand how these contextual factors impact the patient, how it impacts our treatment. And then we still have to learn like motor skills, how to modulate forces. We still have to be confident in the way that we do it. I still think like palpation, it has an effect on people, just like palpating, feeling, getting a sense of the structure and tissue and texture of the patient. Like, is this someone who I need to be, put a little bit more mass into, or should I back off a little bit? Some of those things are still very important to teach. But teaching stuff like, oh, you want to move the bone this way or that way, or you want to hit this angle because then you will impact the disc rather than the facet joints. That is all just outdated information, and we need to update that across, I would say, like worldwide, across all institutions that teach, rather undergrad or postgrad, that teach manual therapy skills. At least when it comes to this popping sound that we investigated, SMT. So that would be my very long answer to your two slightly complicated questions, if that makes sense. And I don't know if you agree or not, but it's my point, at least based on all this data that I have looked at over the last, I want to say, 10 years.
Yeah, definitely follow what you're describing, and excellent answers, Casper. I think also, and this is not different than I think a lot of the philosophy that our listeners are familiar with this podcast. In fact, a more recent publication on the definition of orthopedic manual physical therapy, and that paper was recently published, and I believe Jason Silvernail was on for an interview to discuss that, and how OMPT is exactly what you're saying, not just the application of the hands-on technique, but it's all these other things that go into it. It's the clinical reasoning, it's the choice of technique, it's the contextual factors, it's setting it up for the patient, and what you do before, what you do after, how you weave it into your treatment and plan of care. So I think that is really, really important, and great thing to bring up as we're trying to integrate that into our educational settings, just to increase the skill of our clinicians that we have coming out of those. That's great. So we're running.
Can I add one thing? Sorry.
Yeah, please do. Please do.
Yeah, we're looking into a world now where we understand the complexity of low back pain a lot better. We've done a lot of trajectory research over these last, I want to say 20, maybe 30 years, to see how much it actually varies over time, and how, back in the day we had this definition, acute and chronic low back pain doesn't really make sense anymore. It's either episodic low back pain or recurrent low back pain or simply persistent low back pain. But back pain is never like this, just high all the time. It fluctuates up and down, which means that we're looking into a way that people need to learn how to self-manage. And we have to shift our education and research and clinical reasoning into understanding how can we take this apparently effective intervention, and that is probably in the way that most people understand it is pretty far away from self-management strategies, and implement that into a way where we can use it as a self-management strategy, where we can, reduce the flares, maybe the pain flare-ups, something like that. And we don't really have a great understanding of that at the moment. And I think that's definitely where we need to move ahead. We have to understand that better, because we are looking into a world where back pain is growing more and more, and people have to learn how to self-manage it, because we cannot cure it.
Yeah, I think that's excellent. So it leads into my last question. I could talk to you all day. I think this is fascinating. But
Yes.
Last question for you is kind of looking ahead, and based on the findings from this study that we spent a lot of time talking about, but then also based on the other research that you're involved in, what do you see really now as some of the gaps in the literature, and where we need to focus future research efforts?
If we talk SMT specifically, I would say there are gaps all over the place. There's a huge area of simply research waste, a lot of bad trials, underpowered trials. There's very low funding to the area as well. So that's probably the reason. So I think gaps, we could talk, I could say anything and there would be a gap in it. Like,
Yeah.
let's say, for instance, if you really wanted to conclude whether it mattered to be like highly specific or not, we would need a really high powered trial with like hundreds of people in it to really estimate whether those two things were the same. But based on all of this research, I would say that's not something that we should do, and we shouldn't fund that either, because we have to look at SMT more as having a widespread effect. That's probably the best way to describe it. So even though that's a gap, that's not a gap that I would recommend people to follow, because it will be more of the same. If you do it properly, you know, the two outcomes will be the same for the two groups. That's just it's just the way it will work in 9 out of 10 times. Um, and then, like I said before, how to implement this into self-management strategy, long-term care plans, how to better provide treatment for, I would say, the elderly as well, is something that's going to be really interesting over the next couple of years here as the population grows older. Like a lot of, and also, to be honest, at least in Denmark, and I assume it's the same all around, that older people, they want to do more, they have more money, they have more resources, so like they want to live their life to the fullest when they retire even. So there's going to be a high demand on how to make these patients, or not patients, but these old elderly citizens, how to make them function in a day-to-day basis. And I think that's going to be super interesting and something that we really do need to research. And I would still say, specifically for SMT, mechanisms is still really interesting, and we need more, and we need better research, simply put, on it. And we need to, follow a string where we, find something experimentally, like biomechanically or neurophysiological, and then test that in a like all the way to a clinical population. We need programs that does this, and it's probably not to understand how to give the treatment, but more like who is the responders of the treatment, who should we provide this to, and who should we do something different to. I think that's going to be some of the main things that we have to work on over these next couple of years, or maybe my entire career. uh, who knows. But that's definitely something that we need to look at, which we at the moment don't really have any idea of. And as not just related to this, you could look at exercise, which is much more research than manual therapy. They also struggle to come up with definitions of like trying to predict responders, basically. Very difficult.
Great. Well, Casper, again, thank you so much for joining us on the Hands On, Hands Off podcast. It's been a joy listening to you, learning from you, and we will definitely be following your future work. So thanks so much.
Oh, I appreciate it. Thank you for having me.
Absolutely.